Welcome to the Outdoor Emergency Care presentation for primary assessment. This is Chapter 7 in your textbook. By now you've already done your scene size up, which was covered in a separate presentation. So at this point you know the scene is safe, you've got your standard precautions, you've got one patient, they're unresponsive with a severe mechanism of injury, you're going to need additional resources, and patrol dispatch, I'm on scene. To do that, you've formed a general impression to this is a critical patient that's going to need some life-saving interventions. For the purposes of this class, we're assuming an unconscious, critically injured patient with a lot of life-threatening issues. For a patient with a routine injury who is conscious and talking, you still need to consider all of the steps we're going to discuss. For the practical exam, you'll still need to talk through each of the steps out loud for the clipboard person. The focus in this presentation, and when you do this in class, is to methodically go through each of the steps without getting distracted or drawn into conversation with the patient over and over until these steps become second nature. So you can apply these principles to a real patient when you're under stress without having to think about it. Or you can rattle them off to the clipboard person on the final exam, which is also a stressful situation. For your patients who are conscious, which is going to be most of them, hopefully, you will need to talk to them and not just to the evaluator. So there's a handful of important things you'll need to say or to ask the patient on most of your ski patrol calls. Just quickly to go through these now. We'll discuss these in more detail during the hands-on stations, but introduce yourself. Hi, I'm Matt from the Ski Patrol. Can I help you? You get consent to treat. What's your name? How old are you? What hurts? This gives you their chief complaint. Also want to know, did you hit your head? And that may change how we treat them if they hit their head. And take a deep breath. And how does that feel? Which gives you some of your primary assessment concerns as to their airway and breathing. But for the rest of this, we're going to be considering an unresponsive patient. So assuming our patient who appears to be unresponsive during our scene size up, and the scene's safe, we've got our standard precautions, we've got one patient, they're unresponsive, mechanism of injury is serious, we've called on the radio that we're on scene with an unresponsive patient, so hopefully the dispatcher is paying attention and they're going to send us some help. We crossed our skis uphill so we don't get hit. Now we can approach the patient and begin our primary assessment. The purpose of the primary assessment is to immediately detect and correct any life threats. So our mnemonic for doing the primary assessment is C3 ABCDE. And you'll notice that in the textbook it just starts with ABC, but we've added the 3 C's in front based on the latest American Heart Association recommendations and on the military experience in the Middle East. So don't sit on this slide and memorize these just yet. We're going to go through each of these in excruciating detail, and each of these has several subparts that you also need to know in order. The first C stands for cervical spine. Based on the mechanism of injury we've identified during our size up, if we're concerned that the patient could possibly have a broken neck, we want to be careful of any possible spinal cord injury. For any unconscious patient, it's difficult to assess what happened, and we can't ask if they have any neck pain. So we're going to assume that they do, and we want to stabilize their neck by holding their head in a neutral inline position. Remember, assuming an unconscious patient, you should still talk to the patient as if they can hear you. If the patient's conscious, you want to have a quick conversation and gain consent before you start touching them and grabbing their head. The next C stands for control bleeding or circulation. As soon as possible, if we find major bleeding, we want to stop it. Our whole mission as rescuers is to make sure the patient's body has red blood cells carrying organ to the brain and vital organs. Nothing else we do for this patient is going to matter at all if all of their blood has already leaked out onto the snow. So as soon as you reach the patient, look for any major bleeding. If it's from an arm or a leg, get a tourniquet on there as soon as possible. If it's from the patient's head, neck, or torso, do what you need to do with direct pressure to control the bleeding as soon as you can. And third C is for CPR. If the patient's unresponsive, not moving, and there's no signs of circulation and you can't find a pulse, immediately want to start CPR, starting with chest compressions, call for the AED, and get that process started as soon as possible. Once we've addressed those 3 C's that need immediate action as soon as you reach the patient, we're on to the conventional ABCDE as listed in your textbook. Starting with A, which is for airway. We're going to break down airway into 4 steps. The 4 steps of airway are open, look, clear, and insert. And we have a separate presentation all about airway and breathing. So we're going to go into great detail on how you do those 4 steps and manage the patient's airway. B is for breathing. Again, we've broken it down into 4 steps. 4 steps of breathing are presence, quality, chest, and oxygen. Or are they breathing? What's the breathing like? Check the chest for holes and damage, and administer oxygen. Again, we've got our separate presentation on airway and breathing, so we'll go into a lot more detail when you look at that. C is for circulation, and the 4 steps are bleeding. Again, we're trying to preserve red blood cells, pulses, rate, rhythm, and quality, and perfusion. So bleeding, hopefully anything you needed to put a tourniquet on or to immediately put direct pressure on an artery is already being dealt with. But to preserve red blood cells, if there are other sources of bleeding, you want to track those down and try to stop them. It's also possible the patient may have internal bleeding, some of which will require a surgeon to fix, some of which we can help control by splinting and careful handling, such as fractures of the femur or pelvis. As you listen to this slide, go ahead and try to find your own pulses at the locations described. Try to find the patient's pulses at the radial artery in the wrist on the thumb side. If you can't feel a pulse at the radial artery, then you would move directly to the carotid artery in the neck. The patient's blood pressure is falling from blood loss or other causes. You're going to have a harder time finding pulses out in the legs and arms first, but you may still feel it centrally, the femoral artery in the groin, and the carotid pulse is usually the last to go. You can also find the brachial pulse in the upper arm against the humerus, which is where you check the pulse for infant CPR. On top of your foot, in line with the second toe, is the dorsal pedal pulse. Behind the inside of your ankle bone, the medial malleolus, is the posterior tibial pulse. As you're feeling the pulse, quickly note the rate of the pulse. Later, when we take vital signs, we're going to count it out using a watch. The normal pulse rate for an adult is 60 to 100 beats per minute. So you can quickly get an idea whether the pulse is less than 60 beats per minute, which is 1 beat every second, or more than 2 beats every second, which would be 120 beats per minute. So if it's slower or faster than that, that's abnormal. Generally, you want it to be somewhere in between. The rhythm of the pulse should be regular. If it's not, we say that's an irregular pulse. Quality refers to the strength of the pulse that you feel. While you're in class, you'll be checking each other's pulses. You should get a good idea for what normal feels like. If someone's blood pressure is super high, the pulse may feel really strong, and we would call that a bounding pulse. If their blood pressure is low and the pulse feels weak, we just say the pulse is weak, or thready, like there's just a thread of an artery there that you can feel. Perfusion refers to the amount of blood reaching the tissues of the body. If the patient's perfusion is decreased, we notice that in their skin, which should be normally pink, warm, and dry, now it's pale, cool, and moist. And we can check their capillary refill by pressing on their fingernail. If it takes more than 2 seconds for the blood to come back into their fingernail and turn it pink again, we say that's delayed capillary refill. and you should try that on yourself right now. D stands for disability. For this, we want to make note of the patient's mental status and any neurological issues that are obvious. For level of responsiveness, we rate the patient on the AVPU scale as seen here. Although we've been assuming an unresponsive patient up to this point, maybe we can get some response out of them by shouting in their ear, "Blink if you can hear me," or "Squeeze my hand." Or if we apply painful stimuli by a sternal rub, which is just rubbing your knuckles on their sternum like a noogie, which kind of hurts but isn't going to damage anything. Pinching their trapezius muscle in their shoulder and neck, or pinching their ears. If they don't respond to anything that we're doing, then they are in fact a U on the AVPU scale for unresponsive. You want to remember and document what you did if you got a response and if that status changes over time. If the patient's able to talk to you, you can also assess their level of orientation. Most patients should be able to tell you their name, where they are, what day it is, or at least what month or season it is, and what just happened. Depending on how their brain's responding to a head injury or to a chemical imbalance, they may not be able to accurately answer some of these questions. So if they only know their name and the place, we'd say they're alert and oriented times 2. Again, you'll need to document what they could or could not answer and how that changed over time. The Glasgow Coma Score is a more detailed assessment of the patient's mental status. You don't need to memorize this, but just be aware that 3 is the worst score you can have and 15 is the highest. While we're thinking about neurological issues, we can think about whether the patient may have a spinal cord or nerve injury. We're going to assess this in more detail when we do the head-to-toe exam and when we're dealing with specific injuries. Also, at this point, if we haven't had a chance to deal with stabilizing the patient's head and neck, maybe because we were too busy actually saving the patient's life, I'm going to think about that. E is for environment and expose, which go together because we may need to remove clothing to figure out whether bone is sticking out of the skin or whether there's a hole in the patient's chest. But it's also critically important and potentially life-saving, as well as just great customer service, to keep the patient as warm as possible. This is one of the few things we can do that actually makes a difference, even though it seems simple and stupid. The body does not work well when it's hypothermic, and it really, really does not work well when it's hypothermic and low on blood or oxygen. Remember that you may be warm because you're moving and working and sweating trying to get this patient out of the woods, but your patient's been lying in the snow for 5 minutes. They're probably wearing cotton. They were probably low-grade hypothermic before they even got hurt. So we want to swaddle them with blankets while we're working on them. We want to get them off the snow into a sleeping bag in the toboggan as quickly as we can. And we're going to do this for every patient, every time, no matter how minor the injury, and no matter whether they say they're warm or not. Use the blankets, get them in the sleeping bag. Don't just throw the blanket on the patient's lap. You have to actually wrap it around them and tuck them in. Don't put the patient's blanket on and then immediately take it back off because it's in your way. Work around it, keep the blanket in place as much as you can. After you've completed this primary assessment, you'll continue your assessment of the patient with the secondary assessment, which includes vital signs, history, and physical exam. You'll select appropriate treatments for the patient's injuries, transport them off the mountain, provide further care in the aid room, and arrange for them to follow up with a physician. This concludes this presentation. The next presentation will discuss the critical treatments of airway and breathing.